Good afternoon, everybody. My name is Garrett Schmidt. I am the managing editor for ACO Exhibit Hall, and I'd like to welcome you all to the webinar today, which is a first of a three-part series by HealthEC. It's called Getting Your ACO Through the Crisis, which is very timely. And today's session is part one of that three-part series, which is ACOs during COVID-19, 5 steps to take now. A few items of note as we get started here. All attendees have joined the webinar today in listen-only mode, so you don't have to worry about muting your microphone. That's been done for you. And I'd also like to let you know that the webinar is being recorded, so you will have the opportunity to rewatch it later or share the presentation with others or colleagues. And I will be sending out a link to the recording afterwards, later on today, that will be emailed to all of you. And that'll also have a place where you can download the slides of the presentation. And finally, during the webinar, you will be able to submit questions at any time using the attendee control panel, and no one else can see your questions or who they're being asked by. So and you can submit those at any time, and we will have a Q&A at the end. And we'll get to as many of those questions as we possibly can in the allotted time. But for those that we are not able to get to, we will make sure to respond via email and get back to you so that we can answer those. Okay, without further ado, I wanted to introduce our presenters today. Dr. Jenifer Jaeger, who's the Senior Medical Director of HealthEC, and Dr. Sanjay Seth, who's the EVP and CMIO of HealthEC. So I think Dr. Seth is going to kick us off. So welcome, Dr. Seth.
I guess it helps if I come off mute, Garrett, but thank you. Thank you all for joining us, and hopefully Dr. Jaeger and I can help sort of at least start the discussion on where steps we need to take with the ACOs. We'll start with a little bit of showing one pretty and one ugly face, and I take the credit for the ugliness. Thank you, Dr. Jaeger. Where we thought about a little bit about HealthEC and why we think we are in a position to give some advice on this topic. HealthEC is a population health platform. It has done relatively well over the last few years, in fact, reaching the top of the list last year. And we think we have solved the data aggregation challenge, and our architecture and data models are such that they could be used by different market segments and perspectives, especially trying to develop a strategy and then monitoring that strategy. In the process, we have done many EMR and system connectors and established or built a care coordination documentation system, as well as our analytics. With our current clients, I've just focused on a couple of them that gives you an idea that the advice we've been giving them, whether it's regarding ER use and inpatient care, utilization and procedures, focusing on risk and quality, and with the recent trend of preventing practice and physician burnout, we have had a fair amount of success by helping the organizations focus on this. However, we do think that COVID has posed a different set of questions, and certainly had a paradigm shift. So I'm going to ask Dr. Jaeger to just talk a little bit about the impact of COVID, and she has picked one particular topic that is close and dear to our heart. Dr. Jaeger is an epidemiologist and an infectious disease specialist with experience at CDC and different states. So, Dr. COVID, do you want to take this next step to talk about some impact?
Yes, hi. Thank you for that introduction, and welcome everybody to today's webinar. The focus today is on the impact of isolation and the unintended consequences of being socially distancing yourself from activities with your families and friends, as well as with the medical community. And one of the things that Dr. Seth has given me the opportunity to talk about is our algorithm of how we identify the high-risk patients. And that's just a strategy that we developed based on prospective risk scores and age, known comorbidities, and various other factors such as recent hospitalizations and admission rates, frailty indices, and based on the AI and machine learning and business rules that we employ throughout our platform, we've come up with an algorithm for identifying the highest risk patients, or the patients at highest risk for severe infection due to COVID, severe disease or mortality. And what we have, we've offered this list to all of our clients who have been implementing outreach and contact for their set of high-risk patients. And we have gotten some great feedback on that. One of our large clients with nearly 90,000 patients validated our list and demonstrated a great overlap. We were actually able to identify an additional 25% of their patient population that required outreach and management. And there's been a great impact. We've received the efficacy of our, not just our patient list, but also our outreach approach. And one of the things that has set aside our workflow, different from, I think, what is being done in general, is making sure that the care managers or community health workers and providers assess for the unintended consequence of social distancing. So we have individuals who are remaining at home with now real impaired access to medical care and medications. Food insecurity is becoming a bigger issue because they're not going out to get adequate nutrition, and just transportation in general is showing to be an issue. And another aspect that we're seeing is, and I would include this in terms of our social determinants of health, is looking at the impact of violence. So we're seeing more domestic violence within the homes now. There's an increase in domestic violence reports that is actually being seen worldwide. We're seeing gender-based violence as well as child abuse and neglect. And this is disproportionately impacting women and children and other vulnerable populations, particularly the elderly. And we do see racial ethnic disparities as well with regard to these issues. In addition to the violence, we're seeing increase in substance use disorders, including both alcohol, opiates, and other street drugs. In terms of who we are seeing being most affected, as I mentioned, it's poor and minority populations, but the elderly are particularly vulnerable. And part of the reason for that is that they suffer from a greater proportion of chronic underlying conditions that also require management, and they suffer from depression, anxiety, and pain to a much greater extent due to isolation. And these are all issues that, in terms of outreach and management, need to be addressed. And from an impact here of ACOs, you know, what we would recommend folks looking at is not just whether folks are suffering from COVID infection itself, but again, all of these secondary developments as a result of now not being able to manage their underlying conditions and from being isolated. So we're also seeing an increase, as I mentioned, in terms of avoiding medical care. There are folks that are not going to the emergency room when they should, in fact, whether it's COVID-related impact on their heart or whether it has nothing to do with infection. There is an increase in ambulances arriving to homes where the person has already died. And so we need to make sure that the outreach is is being focused on all aspects of care. We understand that this also will overburden community-based social organizations, and that's another place where having a digital telehealth as such is so important. These are additional touch points that can be made by non-medical personnel and quickly, but importantly, and can be repeated on a weekly basis or a daily basis as is needed. So I think I can go into this later on about how we've helped to address social isolation, but I think that this is probably one of the major focuses now for all ACOs and the healthcare and public health in general. Back to you, Dr. Seth. Dr. Seth?
Mute buttons take a little longer to reactivate. But what I was saying was that the reason Dr. Jaeger and I thought of this as one of the first topics is, we are in this healthcare industry. We have an altruistic nature that prevails, and we didn't want to miss the fact that, as the quote says on this slide, that social determinants of health are responsible for 80% of health outcomes, is the Northwell unit put out. But we thought this was important for us to address. But if you transfer this into the business side, we are now looking at what are the relevant headlines, and there's a couple of screenshots here that sort of I thought would capture what's going on with the marketplace. As you can see from Express Scripts and CVS, as well as Oscar Health, they're all pointing towards one or two things, and that is, we are fundamentally going to change how healthcare is delivered. We can see that as Dr. Jaeger was saying, one of the unintended consequences from a care perspective was the reduced number of trips to the emergency room, or as they call it, dead on site arrival status for some EMR guys. This is definitely, I think, the new norm. I think patient behavior has been impacted. We think that provider behavior is impacted. Certainly telehealth, it appears, both from CMS's perspective as well as operations and practicality, is here to stay. It may have even solved our rural access issues. I think what we used to think about as crowding, whether it's the crowding in the ER, crowding in the hospitals, crowding in physician offices, I think it won't be a topic that we would have to manage in the near future. As all of us, from business perspective, think location. I don't think it's going to be location. It'll become less relevant. Maybe it's just location. I think that from conversations and from the data that we are seeing amongst our client population is procedures are down. I think it'll become, I think that's one of the good consequences of this, that procedures will only be done if absolutely necessary. And as a reminder to all of us, Dr. Google is either first, second, definitely either first or second and not the third opinion. This is a slide that actually shows data comparing 2019 through the beginning of this year, and this is an ACO with the key performance measures. You can see how much to the left that has all moved. I don't think that this is ready to be reversed just yet. And you can see what, for example, what the Blue Cross CEO was saying is that it's a value-based care. And I think most striking is this little graphic headline on the right, where the Kaiser Family Foundation is that the insurers are going to be on the hook for about $2.7 billion in refunds because they would have not met the mandatory spend for healthcare. That is definitely evident in the data that we get on a daily basis, and we are now looking at, May 9th or May 10th data. We are tracking cost and utilization even by diagnosis. As Dr. Jaeger indicated, some of the chronic comorbidities also that increases the susceptibility to COVID infections is certainly on the change. And I think that is a little scary in terms of what Mr. Samet describes as 4 stages, that we are avoiding acute care. We are already seeing that. That the ramp up to COVID and return to normalcy will not be nationwide uniformly seen. I think every area, every state, every local and regional issue of the incidence of COVID or infections is certainly going to make the recovery very different in different parts of the country. We think that elective procedures, elective surgeries, elective or preventive healthcare visits are going to be definitely on the decline, and that has 2 impacts. 1 is on the metrics and 2 is on the revenue. As we can see, hospitals are struggling without elective surgeries. And finally, it is a question of the greater the move towards risk, and capitation and fixed payments is going to be something that we all have to think very hard about recently. I think the response, we were looking at some metaphors, and a dead cat bounce certainly seems appropriate. I'm not sure how much of this bounce is going to be evident immediately. What we do think, as far as ACOs are concerned, is this graphic that says access and preventive and screening, which were on towards the right, are going to be pulling back, and I don't know if they'll come into or they'll come closer to the performance with cardiovascular and diabetic care as we see the quality measures. And as we all know, this is what influences shared savings and return on investment. And so this is what we are warning about, that maybe what do we do next? What we did think about was you might have to take 5 steps, and one would imagine these to be in different directions. They're really not. They're in the same direction. So it's as if you were walking on lily pads, which ones do you avoid and which ones do you put your foot on? And I think that this is where it is, that do not abandon your strategy for value-based care. Do not stop worrying about the ER visits and admissions. They are not occurring. Do not abandon your patient and provider engagement strategy just because the volume is down. You really do need their attention really shortly. Do not ignore your hospital. I know as provider-driven organizations, they have been performing better than the high-cost ACOs, but without a hospital, and especially if you're in a critical access area or a rural facility, if you ignore your hospitals, the chances of their survival come down significantly. And until CMS and the government decides who they're going to support, and this disproportionate distribution of recovery money is still being sorted out. But there are certain entities, the FQHCs, the community health organizations, they're all the ones that are going to be prime targets of this impact financially. And so please do support your hospitals. And I think that something, this is good pause for thought, is that do not stray from evidence-based care. Do not ignore standard protocols. There's a great saying that I've heard, and I don't know who to attribute it to, is that the best business for medicine is good medicine. I think that the more variations we have, the harder it becomes to manage, and makes management very individualistic, and that's not easy to sustain. So these are the don'ts, and here are the do's. Worry about the high-risk patients, and are they disasters waiting to happen just because they haven't been paid attention to? Again, this comes back to identifying those high-risk individuals and staying engaged with them is absolutely, absolutely critical while addressing their social issues. The second sort of step in that direction is to focus on annual wellness visits and preventive care and transition care management and chronic care management, with, of course, a new surge in remote patient monitoring. I know the economics of remote patient monitoring has always been questioned: who's going to afford, who's going to pay, who's going to be willing to do all of this at home. But I think that's the new paradigm for all of us. The advantage of this is also that it does impact physician revenue, and all of these services today, based on the new regulations, both on HIPAA and from CMS on telehealth, have certainly made it possible to do all of this via telehealth. The difficult part for ACOs is that how you're going to get up to speed on the benchmarking on preventive care screenings and patient safety measures. We think that you may not have more than 4 months to do this, considering after Thanksgiving, everything starts to slow down again. They are anticipating a second wave of COVID. So literally, if we are going on the trajectory that we see right now, we're looking at maybe July, August, September, October, maybe a little bit of November, maybe a little bit of June, but between 4 months or less, I think that's when. So what that's going to do is have huge demand on capacity, whether it's resources, supply chain, providers. They can only do so many procedures in a day, mammograms, colonoscopies, cervical screening. So you're going to face a capacity issue, and so one must start planning around that. Family practitioners can do some screenings, and instead of relying on the specialists as well as the facilities. So I think there's a whole lot of planning that needs to be done. I think that as an ACO, one of the things that you should start is, have your contract review or have your contract negotiations begun with the payers, because you need to pay attention and talk about new benchmarking and impact of risk scores or accommodating or including risk in your future agreements. All of that is going to make a difference in terms of how you perform. And we can certainly talk about that using prior year or a whole new paradigm on benchmark. The important thing here is that we are not sure or unable to predict new paradigms, whether it's patient, provider, supply. And I think that the organization needs to be alert and flexible and on your toes to be adapt to new paradigms. So we think that some combination, in fact, hopefully every organization can do all of these things. Again, resources will become an issue. We've had a fair amount of turnover in the healthcare marketplace in terms of the labor force. So all of those will need to be taken into account. But how do we implement all of these, and what is the practicality of approaching some of these engagement strategies? Dr. Jaeger will come back and give us an idea of what we're trying to do or what we're trying to advise. Dr. Jaeger?
Hi, this is Jenifer again. Thank you, Dr. Seth. Dr. Seth is just really focused on a shift in paradigm, and I think that's where care coordination and care management through telehealth will become more of a mainstay. Right now, it's being introduced to our society broadly because of COVID, and although much of what we're seeing now will sort of return to a new normal, I think there will be and should be, in fact, persistent changes, and an increase in telehealth is certainly one of them. From a standpoint of CMS, their COVID-related telehealth codes are only for the duration of the pandemic as of now, but perhaps that will change with regard to persistence in telehealth. But I think we need to focus on this from a standpoint of the ability to make continued touch points to the individuals at highest risk, those folks who are most vulnerable from a standpoint of depression or the social determinants of health, even after social isolation is not a primary issue, as well as their underlying chronic diseases. And so reprioritizing approach on care coordination can focus on predictive risk in a different way. As I mentioned earlier, our algorithms in terms of identifying high-risk patients, the logic to scoring our assessment, and then the way we are focusing our attention has been based on predictive risk for those people particularly susceptible to the consequences of COVID, as well as becoming infected. But this approach may need to change as we move forward with a focus on chronic care or annual wellness visits. And that should translate pretty palpably to improved care outcomes and patient satisfaction. And I think we have to get folks ready to understand that there is a great person-to-person connection with telehealth, that it's not necessarily an indirect approach, and that I think that after some amount of experience with this, individuals will find it to be very satisfying as well, because they're able to be seen more on demand than otherwise. In terms of the HCC, the hierarchical conditions category risk adjustment factor, that is something that we will need to address in terms of maximizing the strategy and the impact on reimbursement for ACOs, as well as other ways that we can focus our energies in terms of improving quality scores, being able to close gaps. One way would be through the medication adherence and the MTM, or medication therapy management program. And then, as I mentioned again, being able to focus on social isolation and social determinants after COVID. We have a large elderly population in the United States that suffers from depression that we're becoming aware of now, but that is certainly still prevalent prior to and will persist after COVID, and their issues should be addressed as well. So we've indicated the way in which we've sort of focused from quality and risk and reimbursement strategies, and then cross these off. And we're not really focusing now on high ER utilizers because people aren't going to the emergency room. We're not looking at those folks who are admitted to the hospital frequently, because right now folks are really not. And these are all, as Dr. Seth said, actually positive outcomes to reduce use where it's unnecessary, but then to make sure that we replace that with good prevention and anticipatory care. Again, I had mentioned earlier about the focus on social determinants of health, such as access to care, access to medications, but access to social interaction, making sure that we are managing their underlying conditions well. And perhaps this means that we have more home visits for blood draws. Maybe we have more home care where we're able to address some of their issues without bringing them into the office, but again, making sure that they're having person-to-person touch points. Within the, our particular population health management platform, we have numerous assessments that allow us to also administer a depression screen, the PHQ-2 or 9, depending on how the individual is doing. We can assess for cognitive functions as well as numerous frailty indices, including the fall risk at home. And at point of sort of that point of care, at the point at which we're, we meaning the community health worker or care coordinator or the medical provider, nurse or physician who's doing the telehealth visit, can actually implement an intervention at that point at identifying what the issues are, and then being able to make referrals, whether it's a food bank for somebody experiencing food insecurity, or whether it's making a referral to a psychiatrist or a social worker to assist with financial issues or depression issues. And I think I've really talked quite a bit about the social determinants. That I don't want to sound like a broken record, but they're important to understand. So I'm ready to wrap this up and entertain your questions. And Dr. Seth as well.
Thank you, Dr. Jaeger. I know we are getting, want to open up the floor to questions and answer anything that has been asked, but we can see that the next topic that we are going to discuss, on how to, what to do during recovery and what the recovery would look like is perhaps just as intriguing. So, Garrett, do we have any questions, or do we want to go to that next stage?
Yes. So we do have some questions that came in, and thank you guys so much.
Okay.
That was a wonderful presentation. And actually, what you're looking at here on the screen now is what I'm going to speak about in just a moment after the questions, and that is the ACO exhibit hall. But for right now, we do have some questions come in, so in no particular order. The first one is, do you predict a change in risk adjustment models such as CMS, HHS, HCC, etc.? I guess that's the first question. Do you predict a change in the risk adjustment models?
Well, CMS has already limited how much of a risk adjustment you could do through the term of your agreement, but it does impact your benchmark. So from an ACO's perspective, whatever little creep we can get, I think that CMS has announced some sort of an adjustment for COVID. It will, what they have described right now is it will not be, it may not coincide or correlate with the actual COVID cases that a particular ACO has seen. They're going to do some sort of regional, local adjustment. And I think that with COVID, we had originally started just to see, one DRG for pulmonary edema, ARDS, be at play, which has its own risk score. But I don't see how CMS could change any of that other than what they have said, which is some sort of an adjustment, whether they do both risk and cost for COVID. I think that the risk adjustment for your commercial contracts may be treated very differently, and depending on the payer, whether they are using HCC or Optum or some other methodologies to calculate risk. But they all have their, positives and drawbacks. So I don't see that much of a movement on risk from CMS. Okay.
And the second part of that question was, are the actual costs of care going to be higher than predicted because of COVID-19? Was not considered in these models?
Well, we've done some modeling, which we think we are planning to share for the next session. But I think that here's a takeaway. 0.5% of your ACO population or less is an ESRD patient, spending somewhere between $75,000 and $110,000 a year. A COVID patient, the incidence of COVID, Dr. Jaeger, we are talking about maybe 14% at risk, and then maybe a 9 or 10% mortality rate at the worst case. Let's assume all your patients in COVID got admitted. They'll be admitted for this ICD or DRG. The reimbursement for that is somewhere in the $15,000-$17,000 range. If the patient expires, that's the number. If they survive, maybe there's a little more. I think on total cost of care directly related to COVID is irrelevant. I think indirectly, COVID may cause other issues now that we are beginning to see, Dr. Jaeger, what is it? We are now seeing neurological and coagulability status, yes, all of that coming into play. So the consequences of Guillain-Barré type syndrome or a hypercoagulable state would have many other, management needs or hospitalization needs. So I think it won't be seen until we start seeing more of those. At this point, as a percentage of your population suffering or being in a COVID situation is going to be relatively small. In fact, our initial model states that you're going to come out ahead, meaning your total expenditures is going to be way below what you would have experienced without COVID.
Great. Okay, moving along. Next question is, we are having difficulty with patients not wanting us in their homes. Suggestions for making them more comfortable?
That's a really good question.
Dr. Jaeger. How fuzzy can we get? How warm and fuzzy can we get using telehealth?
I'm a physician trained in pediatric infectious diseases and pediatric urgent care, and I will say that my experience in the urgent care has suggested that when you have parents who are defensive and don't want you in the home, there's usually a reason. And maybe I'm not suggesting that everybody, please, very clearly, I am not suggesting that anybody who doesn't want you in the home is suffering from abuse or neglect. It's that there's probably a reason they don't want you there. Either they are concerned about the condition of their home, or they are fearful of strangers or their neighborhood. It's something, and I think that it will be the issue of the social worker and the nurses and the individuals who have ongoing relationships with these folks to develop that. And I think as a new norm, to develop the relationship that will allow trust and partnership. And I think eventually, I hope it would be a new norm for those individuals for whom access is an issue. Trying to get to the clinic or the hospital can be problematic. I had patients who, with 2 kids in tow, would take 2 forms of public transportation just to get to their well child check, and that's difficult. So there's such a benefit to being able to provide services within the home, but I do think that it's going to be slow in coming for some folks, and will require really understanding the nature of their discomfort, and then building a relationship that allows them to feel more comfortable with people in the home.
I think it's an individually situation. I don't think we can generalize, but you're right. I think we saw that with chronic care management. Some people wanted to participate and some didn't. I think physicians, if they took the lead on advising the patient on what they need to do, I think would go a long way.
Cool. All right. Yeah, that was a great question. That's a hard one to answer. Next question is, could you please elaborate on how your program interacts with all the evolving social media platforms that most patients use to, quote, stay connected, like Google, Twitter, Yelp, etc.?
That's it's another tough question, but a really good one. We all thought that patient portals, patient apps would solve some of that. Information shopping or newsworthy or worthless information, but unfortunately, with every provider, every organization, every EMR vendor, and certainly a whole host of community-based commercial and not-for-profit organizations have entered into that space, makes interactions really hard. We have been for all our clients, we provide a free patient app and patient portal for communication, dissemination of information, but the adoption rate is still well below what we would desire. But I don't know how we can change that unless we get to a true interoperability state where the patient uses one environment or one access point for all their information. But we do have all of this available, integrating, doing single sign-ons with Google or with Facebook and Twitter on our patient apps and patient portals, but adoption rate is still really low. I don't know if there's a solution for that in this environment when there are so many competing interests for commercial, retail organizations to this population. We have talked about it with the providers, instead of, if the marketing was done to individual retailers and you marketed it through the provider, you reach a lot more people, maybe the messaging stays on point, but I don't think there's a solution that we can offer that, I think everybody's trying something different, unfortunately. Dr. Jaeger, what do you think?
I agree with you. I think the patient app that we have, our mobile app, allows somebody to be more connected with their healthcare and take responsibility, be more autonomous and proactive in managing their own care in a form that is comfortable to use. They're on their phone anyway. But I do think that sort of along the lines of what we said in terms of visiting at home, some people are going to be more comfortable with the digital technology than others.
Yeah.
But there's such a place for crowdsourcing, for having, there's something called Flu Near You, which is crowdsourcing through, it may have actually, it wasn't Google, but it was through a different company. People would report their symptoms and whether they knew they had flu or not. And you could see, and it tracked beautifully. I mean, like very, very well in terms of pattern, not numbers, but pattern, when the flu season actually began. And you could see it tracking along positive flu tests. And so you could see really just by tracking crowdsourcing where infection was starting and where it was ramping up, and it's powerful. So I do think that there's there's a role for this, and I think we're only going to see it interacting more in terms of how does it allow us to integrate within that. That's for another webinar.
Yeah, you could expound on all of these things. Okay, we have time for one more question, and but briefly, we did have one come in asking about the presentation deck or the slide set, and those will be made available after the presentation. I will send out an email to everybody, which will have a place to listen to the recording and download the slides. But one last question here before we wrap up, because we're kind of pushing. We may have time for two very brief questions. Is what is CMS doing with the new applications for ACOs for 2021?
So they've put new applications for 2021 on hold. So they're not accepting any new ones as of now. I don't know if January comes around that they change that, because typically the deadline is July for, to put in the application to start in January. Maybe they'll go to another off-year cycle like they did when they transitioned to these new tracks. I think that remains a possibility, but as of now, there are no, and there will be no new ACOs in the shared savings program with the CMS starting in January. I think we have to stay tuned for July.
And that'll be a change for sure.
Yes.
Okay. In the last question here, and then we will wrap up. And again, for those of you whose questions we were not able to get to, we'll certainly get back to you. So even if you have one coming here last minute, you can go ahead and submit it, and then we'll get back to you via email afterwards. But the last question here is, what would you suggest we include in the discussions we have with commercial payers for the value-based contracts that we have with them?
There's a whole list of points that we should talk about. Again, there are so many iterations of these value-based contracts with payers. Are you being compared to a national trend? Are you being compared to a regional trend? Are they comparing your performance to your previous year's performance? Is the contract risk adjusted? Is the contract benchmarked on both utilization, cost, and or all three, cost, utilization, and quality? Is there a matrix of achieving a certain benchmark? So I think that we want to try and address this in the next session only because there are so many variations. But if I were to start today, I would focus in on where you're going with quality benchmarking, and two, make sure that if they are paying you a care coordination fee, which is the case with commercial payers, the effort, the articulation you should have, or the narration that you should have, is that the effort you're going to have to put in for 4 months is going to have to be exponentially greater than you had anticipated. So the care coordination fees can't stop, because the effort that's going in now with telehealth and what you're going to have to do if the doors open back up is going to be high. So negotiate on that, negotiate on the benchmark. I think at this point, my suggestion is don't bring up total cost of care, because I think you're going to be ahead of total cost of care. It's a little early, but I think by our next cycle we would have March and April's data well digested, so we'll have a true trend on utilization. What we're seeing right now, January, February, it's somewhere between 10 and 20% down already. So if that's the case, do not bring up total cost of care. I think you're going to be just fine. But quality and care coordination fees, perhaps the initial focus.
Okay. Well, very good. Well, thank you both so much. Again, we're out of time, unfortunately, for any questions, so we're going to wrap up. But before we do, I wanted to encourage you to check out the HealthEC booth at acoexhibithall.com, which is what's on your screen right here. And this is where you can learn more about them and connect with their team, watch some videos and read some of their articles and whatnot. And this is also the ACO Exhibit Hall in the library is where you will be able to find an archive of webinars, including this one, for your review and slides download. But again, I will be emailing all of you afterwards with the slide deck and recording, and also keep an eye out. I'll ping you when we're coming up for the next one for part 2, and send you some information about that, so that if you wanted to register for that one as well, you can. Lastly, if you have any specific questions for Dr. Seth or Jaeger or the HealthEC team, their contact information, which was shown here a minute ago, is on the slide. And Dr. Seth, if you could put that on there real quick again for me.
Sure.
There we go.
Yeah, sorry.
So and there's also a code that you can scan, and that will bring up some information with your camera. If you've never done that before, you can just have your camera from your iPhone or your cell phone right onto that code, and that will bring up some information about them. So kind of cool. And they will be happy to get in touch with you for further discussion. So thank you all for attending today. I hope you found today's presentation very informative and helpful, and I hope that you join us for part 2 on June 18th. And I hope you have a great rest of your day, and we'll leave this up for just a moment before we close out. So thank you again for coming.
Thank you, everybody.
Thanks, everybody. Hope to see you all soon again.